I will talk today about AVM surgery. So it's not rocket science, it's neurosurgery, basic neurosurgery, but still I think it's important to have the data on that, especially for the future. Everybody knows Toronto, everybody knows London, nobody knows Düsseldorf. This is Germany. You would expect Munich, you know Munich probably from the Oktoberfest here. You would expect Berlin, it's probably here. So Düsseldorf it's a nice city. So I'm not biased because I'm from Switzerland. It's a nice city. It's in the western part of Germany. And this is our department. Our means Bashir Ahmad and I, we work together. This is our department here, and this is the city of Düsseldorf. So I think a nice city, and I would always like to invite you to come to Düsseldorf to visit our center and the city. For me, it's important to mention these things, especially after this discussion we had in the morning. I do work very close together with some companies, and I think it's of course I am not against brain and I'm not against the heart, but I think it's very important to give and to input into or to have a close collaboration with these companies. And so for the last 2 decades, together with companies like Zeiss or with BrainLab, we developed together some technology aspects, and I think it's very important because we do work with these devices and not the companies, and so it's important to give this input, and hopefully once we can also a little bit try to control costs, which would be ideal. It's important if we talk about basic neurosurgery, it's important even to know data. So I will a little bit talk about epidemiology. Here is one publication demonstrating that the number of images, and this was done from 1995 to 2004, that the number of brain images taken by MRs, CTs, etc., is increasing significant over the last years, and I'm sure that this is the same for Pakistan, so that we will expect a higher number, and I'm talking about AVMs, a higher number of AVMs in the future, and these are same data for the ruptured ones, so it's a stable situation. These are the ruptured, the stable situation for brain AVMs over the last years. The incidence is very low. Age peak is young people who suffer from AVMs, symptomatic or non-symptomatics. The symptomatics are 50% with bleeding, 25 with seizures, and 25 unspecific. And it's of course important to know the natural history of these pathologies. So the bleeding risk might be around 1%, and it's 5 times higher after the first bleeding. And we have a high morbidity, 20 to 35%, and the mortality is 10%. And here you can see the cumulative risk of rupture in patients with AVMs. Here this graph shows patients, and this is from meta-analysis from 2 publications with the unruptured one, so the recurrent risk is less, and with the ruptured ones, the recurrent risk is higher. So this is one point you should take into account if you decide or if you discuss with your patient regarding the treatment. The pathophysiology is known, and I just want to show this image because I do think, and this is from a publication from Michael Lawton, but I do think that in the future, and we have some groups working also on medical treatment. So there is one group in Toronto, Ivan Radovanovic is working on that. There is the other group, San Francisco, Phoenix, and there is also in our department, we are working on drug targets towards AVM. So I think it's important to know the exact pathophysiology of AVMs, especially in the future. And if we talk, or if we talk to our patient, but if you also want to have a structured analysis, we always differentiate between symptomatic versus non-symptomatic AVMs and ruptured versus non-ruptured, and that's everything. That's all, and these are the 4 clusters we need to know. For diagnostics, of course, you know, is clinical investigation important? I mean, we have all the amendment of or the abilities of diagnostics like CT, CTAs, MRs, DSAs, but the clinical investigation is also very important. Ask your patient, for example, about headaches, and these classifications, and I think the most important one is from Robert Spetzler and Neil Martin, is the grading classification. You do know. So important is always the size of the AVM, and this means the size of the nidus. Then it is the venous drainage, and for me it's probably the most important thing. And then the situation, eloquence versus non-eloquence. So the AVM within, for example, the primary motor cortex or not. And then we have a little bit a derived classification from Michael Lawton, which is but basically the same, but you need to know this. And we have the dilemma regarding AVMs, or the treatment of AVMs, that we have the natural history, that we have, of course, treatment-associated complications, and that we can treat our patients by observation, probably some medical treatment, or then by different types of treatments. And the different type of treatments are varies in AVM treatment. It is microsurgery, and that's the topic of my talk. It is the embolization. It is radiosurgery. We heard about it. It's the combined treatment, which was very frequently in the past. I think it's getting fewer. And then we have symptomatic treatment, medication, for example, for patients with headache. And a little bit to understand the history of AVM surgery, we always have to know so I would call it a little bit the game changer studies. We heard about ISAT in the morning. So over the last 2 decades, we had, of course, the ISAT trial in vascular neurosurgery influencing our daily work. Then we had, and we will hear about it later, the COS study focusing on cerebral bypass surgery. And then we had Aruba, which is now for us very important to this topic. Then the big 3 ischemic stroke studies, and we will have hopefully soon results from the CURE studies focusing on unruptured intracranial aneurysms. Coming to Aruba, which was published in 2014 in Lancet. Just very briefly, 233 patients, and these were the results, basically saying that conservative treatment was significantly superior than any other treatment, which means surgery, radiosurgery, or embolization, or the combined treatment. It was as randomized as treated, which is important regarding statistics, and there was no correlation, and we were surprised about this, no correlation to Spetzler-Martin grading. It was highly impact published, and it's thought to be a game changer. Has some reports, for example, in the New York Times, but there was a very big discussion on the results of Aruba, and our society, the European Society, also did a statement, and the title was on apples, oranges, and Aruba. And the major criticism was that Aruba, the results of Aruba, had a mixture of all treatment modalities. Aruba demonstrated an excessive high complication rate. So this is a meta-analysis, complication rates from AVM studies, so non-ruptured AVM studies over the last 4 decades, showing a morbidity of Here you can see from 1 to 3 to maximum 3.5%, and the mortality for Aruba was much higher. Then we had some more criticism. One was the excessive low obliteration rate. There was a non-representative distribution of AVMs according to the Spätzler-Martin grading, which was very surprisingly, and only 5% of the Spätzler-Martin grade 1 and 2 AVMs were surgically treated. I would say a very significant and a very clear criticism to Aruba, though that we had some follow-up studies, and I think this is probably the most important one, published in 2019 with 142 Aruba-like patients. And here you can see that, of course, the morbidity and the mortality was significantly lower than in Aruba. This is according to the modified ranking scale. Of course, this was not the same study design as Aruba, but I think that there is evidence that Aruba was not really right. AVM surgery, I must say, is always highly individual. So there is no standard approach. We do have, for example, like for cerebral aneurysms, it's really highly individual. You have to make your always individual concept for every single patient. And I think that it is very important to understand the angular architecture of the AVM itself. So I do think that still DSA is absolutely mandatory for cerebral AVMs. Then that you have to project the pathological angular architecture into the physiological angular architecture of the brain. And then that you have, again, to project this into the functional area of the brain. Still, classical microsurgical technique hasn't changed that much over the last years, but if we cover the field of vascular neurosurgery, and this is from entrustable professional activities, I would say that the surgery of AVMs is a higher level than, for example, the surgery of aneurysm. Surgical protocol is the same as we use, for example, cerebral aneurysms, for general anesthesia, continuous blood pressure control, normal ventilation, normal thermia, and of course we always use brain relaxation. For me today, it's very important to concentrate imaging, the visualization, and the function, so intraoperative monitoring in one room, which means it is the OR, and I'm sure that this will be much more and more in the future, that we should concentrate everything in the OR. This is a little bit just to show, this is the newest generation from Zeiss, where we work very close together, as I mentioned, where we had the first, like, a little bit, I say it's semi-robotic is too much, but it's the movement of the microscope is automatic. It's navigation controlled, so you don't need anymore your hands to control the microscope. And can do various of AVMs, but just one patient, a young patient, 26 years old, with a history of headaches over the last 4 years. Aruba would say, don't treat this patient. We discussed this over a couple of months. The lady decided for surgery. This is the preoperative DSA, only one slices, and we decided to do this case with intraoperative angiography. Here again, you have the AVM. So if you do your Spätzler-Martin grading, you would end up with a grade, I think 3 is is good for this AVM. So it's not 1, it's not 2, which is important to mention. It's 3. So it's a little bit the borderline. Then you do the surgery. I think that for AVMs, and this is completely in contrast to aneurysm surgery. For aneurysm surgery, as we mentioned yesterday in the course and today in the morning lectures, I think that we can use keyhole approaches for AVMs. It's not the same situation. You need a wider approach. Then you do ICG. I like doing ICG for the AVMs because I do understand intraoperatively much better the angular architecture of the AVM. Then you can do this flow, the semi-quantitative flow measurement. Again, only to see the primary feeders, the secondary feeders, probably en passant vessels, and then the draining venage. And then you do your microsurgery as you are used to do it. I think it's not a sprint. Take your time. You have to close every primary feeder, and you work around the AVM. Don't touch the venous drainage. It's otherwise you risk intraoperative bleeding. But yeah, well, this due to time, I will skip a little bit. You can repeat ICG angiography again. Here you can see the clips, and you can see an effect of the clips, and then really work around the AVM. And you can do this surgery very, I would say, bloodless without any complications. So then I would like to conclude that Aruba was not a game changer. It gave us much more evidence towards microsurgery. And I am not that pessimistic, as we heard in the morning, regarding the future of vascular neurosurgery. I think that this is still a big field for us. We have to get better. We have to be very innovative, but I think we can do that. AVM surgery is always an individual concept for each patient. It is always a multidisciplinary approach. So do your proper diagnostics, and that I think that, and this is more the situation, I don't know the situation here in Pakistan, but for Germany, that we should do this type of surgery in vascular centers with a certain kind of a certain amount of volume. Team approach. This is our inner circle. My senior colleagues, probably you know Sajjad Muhammad on the right side, more the junior colleagues. Again, thank you very much for me having me here, and thank you very much for your attention.